Thank you, John. Good afternoon, Prof. Saku. Friends, ladies and gentlemen. I'm not going to go through on asthma management. I think that would be too boring for you. But instead, I'll be looking at a more practical aspect, looking at what are the challenges that are facing us in the management of children with asthma. And I look at it from 2 points. I think the first thing is being able to commit to a diagnosis of asthma. I think that for children particularly, that is the first challenge. And the second challenge is having made a diagnosis of asthma, how do we overcome the obstacles that we have in the care delivery to make sure that we are able to carry on with the treatment according to the steps that's recommended in the guideline. In childhood asthma, it's no different from adult asthma. The symptoms are similar. But making a diagnosis is not as simple because the hallmark, which is wheezing, is a very common symptom in children. At least a third of the kids will have at least one episode of wheezing in their life or bronchiolitis. Some have recurrent episodes. So that makes diagnosis of asthma in childhood a challenge. There are many patients who can present with wheezing and yet it's not asthma. And there are patients who have asthma who do not present with any wheezing. They just present with a chronic cough. So in pediatrics, taking a detailed and careful history is critically important in coming to a close diagnosis. And sometimes we actually cannot be certain of whether this child is having asthma. This is one of the criteria that many pediatricians use to help us in deciding whether we want to treat a kid with at least 3 to 4 episodes of wheezing if there is a parental history of asthma and that child has eczema. That puts the child at very high risk of asthma, and very often if they have recurrent wheeze, we would want to treat this group of kids as asthma. So not every single child with recurrent wheeze we will treat as asthma, but if they do have atopic features in the family, and the kid themselves, then this is a very good indication that this child with the recurrent wheeze need to be treated as asthma. So personally, I find this a very useful guide in clinical practice when you can't decide whether you need to treat this particular child. I'd just like to share with you some of the pitfalls that we mentioned earlier on, that they can present like asthma and yet they may not have asthma. This is a 5-month-old child that has been treated for wheezing by various people along the way. The history is that the child had cough and definite wheezing since the age of 3 months. And this is from a child with a strong family history of asthma. So the parents say, now I know what is wheezing and my child is definitely wheezing. So this child has gone through a lot of treatment, much more than you would expect for a child of this age, including oral steroids. So that actually makes you a bit worried because a lot of treatment has gone into a very young kid. But there is definite bronchodilator response. The family will tell you that after nebulizer, they are very sure the child is better. Okay, but the fact that with that, the child comes for 3rd or 4th opinion tells you that something is actually worrying this family. Why is it they keep on going to various doctors when they are very sure that there is bronchodilator response in this child? So when I saw this child, it was quite definite the child had audible wheezing. You don't need a stethoscope. He's atopic, he has eczema behind the ears, his cheeks, his elbow, and yes, he has bronchodilator response. But what is important in the careful examination is that when the child gets better, it is quite evident that this child has something else. You see, but even looking back at this patient, are there things that tells us that this may not be a straightforward bronchial asthma? Yes, the onset is very early. If the history is given 3 months of age. The child seems to have persistent symptoms. They say, yes, the child gets better, but the child keeps on seeing another doctor. That shows that the symptoms are still there. And with such strong treatment, including steroids, you would expect the child to respond, but obviously the child is not. So all this is important. And that's where the last step when we saw the child is the stridor that was present. That tells us that, okay, besides the wheezing, there's something else wrong with this child. And a very simple chest x-ray tells you that this is not a straightforward asthma. You can see the trachea being shifted to one side, very clearly shifted to one side. And of course, bronchoscopy shows the obstruction very clearly. And this child now carries a big scar, thoracotomy scar, because he actually has a esophageal cyst. But do we want to continue treatment of asthma in this child? Now that we find that there's an underlying cause. I actually thought quite carefully over it, and there are a few things that first, there's a strong family history of asthma. Secondly, there is personal eczema in this child, and there's a good bronchodilator response. So for this particular child, I continue with anti-inflammatory therapy for another 6 months before it was taken off. But this is just to highlight to us that a case that presents quite typically like an asthma, audible wheeze, good bronchodilator response with eczema. But if there are some atypical features at the onset, the response to the treatment is poor, persistent of symptoms, it is very important to go back and take a detailed history. Okay, that is the difficult part about diagnosis, but if we are careful, we spend time taking history, that should not be a major issue. The next step we need to identify is what are the barriers that's facing us as clinicians managing this group of children. I think if I summarize from my own perspectives and from what I hear from my colleagues, the first thing they tell me in kids is very difficult to make a diagnosis. And I'm sure most of us here will agree, and in kids, this may not be easy. We always complain that the parents don't understand the disease, they don't understand the condition, therefore, they stop the treatment whenever they like it. They over-rely on reliever treatment. They all have poor perception of the severity of the disease, and they always complain about the dollars, about the treatment costs of asthma. When I ask parents and try to see from their perspective, what are the issues they have about asthma? They tell me that, well, very often the doctor don't give me a diagnosis. They say, maybe asthma, maybe bronchitis, maybe early asthma. I'm really not very sure. Then we ask ourselves, did we say all this? I think, to be honest, very often we do. Okay, because we are afraid to make a commitment to the diagnosis. So the doctor did not inform them. How many of us spend time and talk to them about chronic condition, about the chronic inflammation and the need for long-term treatment? I think we have to ask ourselves, do we spend adequate time? How often do we assess the severity of disease and tell them that, look, your child has a severe form of asthma and you need to be closely monitored and follow up? Sometimes we don't. In the institution, we do it regularly, but I heard from my GP friends that they try not to do it because they're afraid. The parents say, why you ask me to come back when the child is well? So we do need to explain to them the importance of monitoring and follow up if you want good control. And very often they say, I don't agree with the treatment the doctor is given to my child. And of course, they are also about the cost. They're also worried about the cost. So if I put the two side by side, you can see that actually there's no conflict. Okay, we have difficulty making a diagnosis, and therefore they complain that we did not make a clear diagnosis. Okay, we say they don't understand the condition, but they reflect to us that it's because we have not given them enough information. We say they over-rely on the medication. They say, because I don't have faith in the medication you gave me. And poor perception of disease, they say, well, I was not told that I have a severe condition anyway, or my child has a severe condition anyway. So just by looking at the barriers, we actually from here, we know what are the areas that we need to focus in order to make sure that we are able to manage the asthma well. I think it is important to get the diagnosis right the first time. Try to spend enough time on the first consultation to get a good history and get the diagnosis right the first time, because that will save a lot of hassle, unnecessary costs once you get the diagnosis right. But if you are not certain, it is important to be open to the parents and explain to them the steps that you will be re-evaluating and what are the possible other diagnoses that we are considering and what we'll be doing. Because with the current information they achieve from the internet, they actually know much more than in the past. Personally, and most of my colleagues will agree with me that for pediatric, we still feel it's very important to make an assessment of the underlying severity and let the parents know. Because you have to prepare them for the journey that it's going to take. Is it going to take weeks? Is it going to take months? Is it going to take years? Parents need to know that. So for pediatric, it is still very important, but we won't go by the complex assessment. We just divide them into two groups. The group that is intermittent and free from interval symptoms, infrequent symptoms, you just don't do regular treatment, you just use intermittent treatment. And the group that have persistent symptoms more than once in a week, or who have exercise limitation, just remember that group, we are going to put them on treatment. So it's quite simple. No need to remember the complex classification. Just remember which group that don't need treatment and the other group that needs treatment. So just a few key points about therapy